Well, I'm pleased to be joined today by Vivek Jha, who's the Executive Director of the George Institute for Global Health, India. He's also a professor of nephrology and James Martin Fellow at the University of Oxford, and he has a co-joint professor of medicine at the University of New South Wales in Sydney. And he's also the current president of the International Society of Nephrology. So Dr. Jha, thank you for joining us for today's discussion.
Thank you for inviting me, Todd. Pleasure to be here.
So I have to start with a interesting coincidence, which is that you and ASN President Anupam Agarwal have known each other for quite some time. When did you first meet?
Well, that's really interesting. I don't think there's ever been this coincidence, and perhaps there will never be one again. But Anupam and I met during our medical residency. I was 6 months ahead of Anupam in our institution. So I actually met him in July 1986 when he came down to do his medical residency. And since then, we have known each other. So we trained in medicine and then followed by our training in nephrology together. And we spent some time after our training doing a kind of semi-faculty job here before Anupam moved on to US, and I continued in the same position. So we go back more than 32 years now. During his medical residency, he did a project which led to the first publication in the journal Kidney International from India. So that was a time really that marked Anupam for greater good. And it's not a surprise that he has risen to where he is, both in terms of his professional accomplishments and in terms of his service to the nephrology community through various societies, including the ASN, of which he is the president now. Very deserving.
I hadn't realized that he had the first publication from India in Kidney International. We'll come back later in the discussion to talk more about ISM, but I'm just sort of curious as to what you're seeing with Kidney International in terms of submissions related to the COVID-19 pandemic.
Like many journals, Kidney International has published a significant number of papers, original papers, as well as review articles, commentaries on COVID infection. The same has been seen in other journals, including the Journal of American Society of Nephrology, the Clinical Journal of American Society of Nephrology, and other journals as well. I think in terms of the number of publications that we have seen in the last 2 or 3 months, COVID has been quite remarkable. In general, I have to say that the number of good quality papers has been actually outnumbered by the number of poor quality papers. And when I say this, I am excluding Kidney International as well as the CJSN from that list. But I think we just need to be careful about being able to separate good science from bad science at this time when publications are a dime a dozen.
Yeah, and it's interesting because both organizations have such an important role related to being publishers. And so I think the point you're raising around the peer review process, the importance of the quality of how seriously the editors take the quality of what they're producing and some of the challenges we're having with other journals, a lot outside the kidney arena, but also just how the publishing industry is changing and how that's going to alter, I think, moving forward, how we both curate but also distribute information is really an interesting issue, and obviously something that ASN and ISN share as goals because of their role as publishers.
Yes, indeed. So in Kidney International, at least, whenever a COVID-related paper is submitted, since it is so topical and a rapid review is important, but so is a rigor of the review. So generally, one of the editors would kind of shepherd the paper, find reviewers who will be willing to perform a rigorous review over a relatively short period of time, turn it back to the authors for revisions, if any are required, and then work with them in really making sure that the final product that comes out is not only worthy of the publication, but also worthy of the authors who actually start the work. We recognize that some of this work comes from countries and places where English is not necessarily the first language, and many of these researchers have not had the opportunity to write too many papers. So doing this kind of hand-holding is important, and I'm sure other journals like CJASN are doing the same.
I wanted to circle back to the situation with COVID-19 in India. If you could just sort of describe currently what's happening and sort of the progression of the pandemic in your country.
COVID-19 remains a very active problem in India right now. So even though we had our first case in India towards the end of January, for about 6 weeks or so, there weren't too many new cases. And it produced, in a way, a false sense of security that perhaps India was going to escape. But of course, biology always catches up. And it was around the first week of March, then when it started to become apparent that COVID will hit India, as it was sort of ravaging other parts of the world, had started to flare in US, was already raging in countries like Italy and some other Western European countries. And so that was the time the healthcare authorities in India woke up to this. And one of the first things they did was to announce a lockdown. So that lockdown came into effect mid-March. The lockdown has been lifted partly in some areas of the country. But during this time, one has seen a number of cases, the number of cases going up almost constantly. Although we haven't seen a rapid surge in large number of cases, I would say that is partly because we are not testing enough number of people here in India. India has one of the lowest per capita testing rates in the world. So it's difficult to kind of project where the trajectory of cases is going. It's fair to say that we are not seeing any decline in the number of cases. The number of new cases being discovered is going up day on day. Just like in US, there is significant geographic concentration of cases in some cities. For example, in Mumbai, where there are slums and people live in very difficult circumstances in crowded housing. They don't have always access to running water. We talk about hand hygiene, but these people don't have the luxury of practicing hand hygiene or even maintaining social distancing. And so when even one or two cases of COVID erupt in that community, it's likely to spread very quickly, which is what we are seeing. In addition to that, in India, since we are what the World Bank describes as a middle income country, this story is going to be repeated in other countries with similar economies, where we have a large number of people who are very poor and depend on almost daily wages for survival. So during the lockdown, suddenly they didn't have any work. In many instances, they didn't have any roof to live under, and so they didn't know what to do. As a result, people tried to get back to their homes, which led to large-scale migration of people, which was very unfortunate. And since public transport had stopped, these people didn't have a way to sometimes travel several hundred kilometers, and there were heartrending stories of people walking across. So it's been difficult. I think the problem has been both medical as well as sociological, which has impacted large sections of Indian society. The story has mostly been told about what the situation is in urban areas. We don't have sufficient information about what is going on in rural communities. Once the lockdown is lifted and the movement of people from urban to rural parts of India begins, I'm afraid we can see increase in the number of cases even in rural areas, but that all remains to be seen. As I said, the cases in Mumbai, Chennai have increased quite rapidly in the last few days. So all the hospitals there that are managing COVID patients are more or less full, and very soon it looks like they will run out of capacity. Now, one more pertinent thing to point out here is that the healthcare system in India is is weak, and this is again a feature which is common to many countries that have similar economies. So in the presence of this weak healthcare system, the ability of the system to respond in a resilient manner to any acute stress is minimal, and that is what we are seeing. We don't have enough workforce to be able to do sufficient degree of contact tracing. So the frontline healthcare workers in the community who provide care to pregnant women and young children, they have been pressed into service in identifying and tracing patients with COVID. What this has done is to take away the ability of the health system to provide care to patients with pre-existing conditions like cardiovascular disease, like diabetes, like kidney disease. These people have been deprived of their ability to go to their hospitals because the hospitals are closed to all non-emergency services. Telemedicine has been helping a few people, but again, not everybody has access to those tools by which they can contact their doctor using one of these technologies. Supply chains have been interrupted, which have led to scarcity of availability of essential medicines. There have been challenges in providing care to patients with kidney disease, such as those who are on dialysis, because they are either not able to access their dialysis centers due to lack of transport, or some of the dialysis centers have reduced their capacity because they have had to stagger their staffing patterns. They have had to reduce the number of beds because of the need to maintain appropriate distancing between the two beds. So suddenly, these people have had to find ways of either making do with reduced number of dialysis, and sometimes they have to present in an emergency situation to emergency rooms, which obviously means that their outcomes are going to get worse. So there are a number of challenges which are related to the way the healthcare system is structured, and I'm afraid that this is something which India shares with many low middle income countries.
I'm curious in terms of decision making from the government. Is the situation in India where it's centralized and it's coming from a national level, or is it more of a situation that we face here in the United States where the individual state has been taking the lead in sort of determining what works for that individual state as opposed to a more federal response?
That's a very good question, Todd. So as you know, India is a country of 1.35 billion people. It has a federal structure, so there is a central government that makes policies, but then we have states that decide how to implement those policies on their own. So even though the federal policies have been decided in the case of coronavirus response also by the union government, but states have taken their own different paths of implementation. So as a result, a few states have done better, and terms like model are being used to describe the practices. So worth mentioning is the example of the South Indian state of Kerala, which has better public primary healthcare system in India and greater degree of resilience. This has traditionally been the case. So the response by Kerala has been much more proactive, aggressive, and they have been able to contain the number of cases in that particular state. There has been a significant difference in the response of different states.
Just so we can understand, in terms of the different states, is it a situation, again, I'll use the United States as a comparison, where you have some states that are primarily urban and others that are more rural? Is it the same sort of division in India, or is each state have both a large urban and rural component?
There is not much of urban-rural difference in India by way of difference between states. So about 60 to 70% of Indian population is rural in pretty much all states. However, social development indicators are different in different states. So the South Indian state of Kerala has the best social development indicators out of all states in India, both in rural and in urban areas. They have a more resilient primary healthcare system. even in other times. And so their response to the coronavirus pandemic has also been more agile, and they have been able to contain cases much more effectively and provide care to people with other conditions also in a more systematic manner. On the other hand, there are a few other states which are relatively backward with poorer social development indicators and less developed health systems where the response has not been as good. As a result, those states have even more limited testing abilities, and the number of cases have been going up relatively rapidly there.
Shifting gears a little bit, we had talked in the beginning about your role as the president of the International Society of Nephrology, and I'm curious as to how ISN has responded to the COVID-19 pandemic.
So the ISN was impacted very strongly by the COVID pandemic, but in a very unusual manner. The International Society of Nephrology has its World Congress of Nephrology, and the 2020 World Congress of Nephrology was planned for the end of March in Abu Dhabi, which is right when COVID pandemic hit. And we had to make, at that time, which seemed like a very difficult decision to cancel the World Congress of Nephrology. Now, in retrospect, even though it has been less than 2 months, it sounds like it should have been such an easy decision to make. So that was our first impact of the COVID pandemic. But once we had put that behind us, the ISN recognized the need for information sharing and knowledge exchange between the global nephrology community. And so, like most other renal societies, such as the ASN, the ISN started collecting information which would service the information needs of its members and disseminated it through the standard portals like the website. The ISN has an academy, education academy, through its journals. We talked about Kidney International before. So the Kidney International rapidly published a few peer-reviewed papers. The online content rapidly increased, and it was realized that we need to provide information that alleviated anxiety amongst the members and helped them coordinate their action. We thought the best way of doing this was at that time when information was still sketchy, to try and learn from the experience of the communities that had indeed been dealing with this. And so the ISN organized a few webinars in which we had participation from Italian nephrologists, and subsequently a series of webinars and even podcasts in which we learned from nephrologists in different parts of the world, United Kingdom, United States, Western Europe, even from China, about how they were doing and dealing with this pandemic in their hospitals, both in terms of general medical care, but also in terms of specific kidney care issues, about how they were dealing with shortage of dialysis equipment, helping patients get appropriate kidney care. While we were doing it, we also realized that there was a strong need for advocacy to make sure that even the non-renal community understood the value of providing appropriate attention to kidney health. And to that end, we reached out to the American Society of Nephrology and the European Renal Association, and we crafted a statement of solidarity calling for not only better care for patients with kidney disease or those who are at risk of kidney disease, but also for protection of healthcare workers who are taking care of these patients, and to the governments to make sure that any glitches in the healthcare system that hampered this kind of care should be addressed. The ISN has an official relationship with the World Health Organization, so we lobbied the World Health Organization, and the WHO is currently in the process of developing some guidance on ensuring provision of care to patients with pre-existing chronic conditions, and that guidance, when it goes out to the government, will hopefully spur them into action. So This has been the response in terms of kidney care, but we have also started interaction with other societies that deal with other non-communicable diseases. For example, diabetes, cardiovascular disease, through the Global Coalition for Circulatory Health, and other societies, even of other kidney professionals like the Renal Pathology Society, the International Society of Hemodialysis, the International Pediatric Nephrology Association, because even though this disease does not affect children so much, it is their caregivers who get affected, and thereby the lives of children is indirectly uh, impacted as well.
I'm struck that ISN's both philosophy and approach has been so similar to ASN's, and just to highlight and commend you for the joint statement that ISN led and then was co-signed by and developed by the current president of your ADTA, Professor Carmen Zakali, and Dr. Agarwal from ASN. That statement, which was issued by the three societies on Tuesday, April 28th, is entitled Ensuring Optimal Care for People with Kidney Diseases During the COVID-19 Pandemic. And I think it generated a fair amount of attention both in the traditional media, but also, as you mentioned earlier, on social media. And I think there's probably other opportunities as we move forward over the summer through the fall into next year, living with this pandemic and trying to navigate it. The three societies can continue to collaborate and complement one another in terms of our efforts. And so I just wanted to commend you for everything ISN's doing, but also taking the initiative in terms of this joint statement, because it really would not have happened without your effort.
No, thanks, Todd. I think, as you say, we are in a kind of world which I think has not been seen by people in several generations. We have to not only deal with the current catastrophe of the COVID pandemic, but I think by all accounts it is clear that this situation is going to stay with us for some time, and the long-term consequences of this pandemic will be felt for several years. Not only economic consequences, but health consequences. How we deal with different health situations. How do we see our patients in our clinics? How do we provide emergency care? In someone who suddenly lands in ER and requires some kind of procedure, and we don't know whether that person is COVID positive or negative. How will we deal with that situation? Not only in a fully equipped hospital, but also in a remote hospital located in some rural areas of Uganda or of Peru or something. We have to think about how do we do teaching in the post-COVID era. What will happen to medical bedside teaching? Will it still continue in the same way, or we'll have to find some different ways of doing it? How do we do research? One of the important things that as a researcher I have been acutely conscious of, and I'm sure there are many other colleagues who are being impacted by this, is the effect it is having on clinical trials as well as basic laboratory research. Many clinical trials have either stopped or patients are not able to receive investigational treatment. Clinical trials are so important because they generate information which will shape how we treat our patients, inform us of the safety and efficacy of different treatment approaches. So we have to think all of this, and that can happen only through global collaboration. We have to develop ways of having open platforms to exchange information and to learn from each other, and make sure that the information that is generated in one part of the world is shared wherever there is need for such information.
Well, Vivek, thank you very much for doing this. I really appreciate it, and I enjoyed talking with you, and I hope you continue to stay healthy and safe, and hopefully we will see each other again in person soon, but I recognize that may be some time now.
Thank you, Todd, and I want to thank all the listeners of the podcast, to the American Society of Nephrology, and of course to my very old friend Anupam Agarwal through this. It was a pleasure.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition, or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.